Hello and welcome back. Today I'll be trying to derive a generalized diagnostic framework for the assessment of musculoskeletal pain. This will be the second discussion in our approach to musculoskeletal pain, and I'll be approaching it under the following headings. So, first, we'll try to understand the role of base rates of musculoskeletal disorders and how that figures into the construction of our diagnostic framework. Secondarily, we will develop a sequential generalizable diagnostic framework for musculoskeletal pain. And when I use the word generalizable here, I mean it will be usable in multiple clinical scenarios, much like a math equation, an algebra. And then we'll try to understand why and how the term inflammatory arthritis differs from inflammation as understood generally, the term inflammation in pathology. Then we'll try to extend this framework to account for the oddities of the pathogenic mechanisms of inflammatory arthritis that were discussed in part 1. So in order to follow the discussion easily, I would strongly suggest that you watch part 1 of this series first. Then we'll try to understand how we use this high base rate and specific joint distribution of rheumatoid arthritis to differentiate it from arthritis that develops in polygenic alpha interferonopathies. And finally, we'll try to describe the role of synovial fluid analysis in this diagnostic framework. Now, there's also a bonus section on how to differentiate rheumatoid arthritis from polyarticular psoriatic arthritis. So we'll get to that just before we discuss synovial fluid analysis. Okay, so MSK pain, like any other diagnostic framework, the base rates of disease matter a lot. So what does that mean? That means this is just a representative distribution of the actual causes of pain, musculoskeletal pain, in a general setting. So this is actually very approximated data, but this is likely to represent the actual fact on the ground. So as you can see, most commonly musculoskeletal pain is the result of trauma, whereas significantly less commonly, but still in about 8% of cases, it is due to degenerative arthritis. And inflammatory arthritis accounts a very small portion of the pie, so it is quite uncommon. So when we try to diagnose inflammatory arthritis, we are essentially working against the odds. We're climbing a mountain. So the starting odds of inflammatory versus degenerative or post-traumatic MSK pain are 98:1, or 98:2, or 49:1. So our clinical presentation has to offset that. Okay, so that is why it is important to take into account the base rates of these disorders. So let's see how I go about doing that. So first, what I look for is the pain acute or focal, or involving one single part of the musculoskeletal system. That would be a pain such as this single knee pain. Okay, and then I look for red flag signs. So what are these red flag signs? These would be fever, antecedent history of trauma, very rapid progression, local rise of temperature, things like that. Okay, so they indicate that it might be septic arthritis, it might be gout. They could also indicate fracture, vascular ischemia of the bone, or in less commonly carpal tunnel syndrome. So all of these entities by far always present with focal involvement. Okay, a single part of the musculoskeletal system is affected predominantly. On the other hand, we could have a multifocal involvement. Now if it is multifocal, then these entities become slightly less likely. They're still common but not as common, so we've removed those entities from our consideration. Now once it is multifocal, we need to decide whether the pain is actually arising from the joint or is it arising from outside of the joint. So is it articular or is it extra-articular? Now for extra-articular pain, first the pain is, what I like to do is I like to take the example of teichovein tenosynovitis vis-a-vis your wrist arthritis. Okay, So obviously, because the tendon here is superficial and right below the skin, the pain is also superficial. The pain is there only in the direction in which the tendon is stretched, or in which it contracts. So it is only there when, say, the wrist is moved in a radial direction or an ulnar direction. It is not there when the wrist is flexed, when it is dorsiflexed, or it is extended or flexed. On the other hand, the pain is more appreciable when there is passive movement as compared to when there is active movement. Okay, that is when somebody moves the joint for the patient, the pain is much more, whereas when the patient is performing active movements, at that time he or she voluntarily avoids exacerbating the pain. Okay, now finally, swelling obviously would involve only one part of the joint. Now on the other hand, in case of articular pain, the pain is deep seated within the joint. It is there in all directions of movement of the joint, because the joint is a three-dimensional structure. Third, the pain is there in both passive and active movement. It is approximately equal in magnitude in both. And finally, the swelling, because again the joint is a three-dimensional structure, is all around the joint. So in case of the wrist, it would be all around the wrist. In the dorsal aspect, the ulnar aspect, the radial aspect. The ventral aspect, it may not be apparent, because obviously there are a lot of tendons ventral to the wrist, but you get the point. Okay. So once we've done this, we decide whether it is an extra-articular or an articular pain. Now, after that, we divide the multifocal musculoskeletal pain into extra-articular and articular, or non-articular and articular. So when it is extra-articular, now the main consideration here is it likely to be either a bursitis, tendinitis, or muscle pain, okay, or myositis. Now obviously, if there is antecedent history of trauma, then you would consider bone pain such as fracture, secondary to fracture or trauma as well. Now, under very specific circumstances, as a diagnosis of exclusion, we can consider fibromyalgia also. And in older people, typically older than 50 years of age, we can consider the possibility of polymyalgia rheumatica. The pain there in that case would be very prominently symmetric, proximal, and associated with early morning stiffness, and would not localize to any particular joint. Now, in case of articular pain, we'll go to the next slide. So articular pain, the best way to go forward is to decide regarding the duration of pain. Why is this? This is because if the articular pain has lasted for less than 6 weeks, that is, it is an acute arthritis, it is, in a 9:1 odds more likely to be a post-viral arthritis. So we divide the entities into two groups, that is less than 6 weeks and more than 6 weeks. So at less than 6 weeks, we call it acute arthritis, and acute arthritis has got a very skewed distribution towards a viral arthritis. So 9:1, like I just said, in favor of viral arthritis. Other possibilities that you must consider are septic arthritis, crystal associated arthritis, and reactive arthritis. What I do is I use a mnemonic for this, that is whisper. Okay, so whisper. Okay, so VI stands for viral arthritis, S stands for septic arthritis, P stands for pseudogout, and naturally also gout, and R stands for reactive arthritis. Okay, so you whisper these when you're considering acute arthritis. Okay. Now, in case of chronic arthritis, the next step is to look for features of quote-unquote inflammation. Now, this inflammation is actually not what we consider as inflammation, in case of pathology. So, in the study of disease, that is histology, the term inflammation has a very specific meaning. Here, that meaning is not the same. So here the term inflammatory arthritis is supposed to describe certain features of the joint pain that increase the pretest probability of the joint pain being the result of inflammation. Okay, so this just increases the pretest probability. It is not a definitive thing. Even non-inflammatory arthritis could be actually, and there could be underlying inflammation, and what we call inflammatory arthritis could actually be non-inflammatory arthritis. So, but it does predict with good correlation with the final outcomes. Obviously, we cannot do histopath, and it is not clinically prudent to do histopath in every case. But yeah, it does increase the pretest probability. So what are the features that we look for? So in case of a non-inflammatory arthritis, non-inflammatory arthritis is aggravated by activity of the joint. Okay, as long as the joint is immobile, there is no pain or very minimal pain. It is relieved by rest. It is associated with a swelling sometimes, but redness and local rise of temperature is unlikely to be present, and it is associated with a very short early morning stiffness of less than 5 to 10 minutes. Inflammatory arthritis is aggravated by rest, which is the reverse. It is relieved by activity. It is associated with redness and swelling and local rise of temperature sometimes, and usually the early morning stiffness is more than 30 to 60 minutes. Now the exact cutoff used depends on the situation. For example, in spondyloarthritis we use a shorter cutoff of around 30 minutes, and in RA the 1987 classification criteria use 45 minutes. The present classification criteria doesn't say a specific duration. Okay, so but however, the cutoff obviously depends on the receiver operator curves, and that is a balance of sensitivity and specificity. So higher the cutoff that you keep, the higher the specificity. That is, longer the duration of early morning stiffness, the more specific it is that it is inflammatory, and the shorter it is, the less specific it is, but the more sensitive it is. Okay. Now, once you've decided whether it is inflammatory or non-inflammatory, just prior to going ahead from this, the one important thing that I need to highlight here is that the term the early morning stiffness is specific only for inflammatory arthritis. It is not specific for any one particular type of inflammatory arthritis. Okay. Now, why do you get this early morning stiffness? Now, actually, the primary reason for this is the diurnal variation in the production of interleukin 6, primary interleukin involved in the innate immune system, along with interleukin 1 and TNF alpha. So that is the primary reason. Possibly older literature says that decreased movement of the joint results in decreased removal of pro-inflammatory mediators from the joint, but that is neither here nor there. The prolonged nature of the event and the specific diurnal variation strongly points to it being due to interleukin 6. Okay. Now, what are the other features of inflammation? So we go ahead and we divide it into arthritis with features of inflammation and without features of inflammation. Okay. So in case of non-inflammatory active chronic arthritis, now this is chronic and it is non-inflammatory. Okay, so more than 6 weeks, but no features or clinical features of inflammatory arthritis. So here we again by far the most common cause of non-inflammatory chronic arthritis is osteoarthritis. So osteoarthritis has a very specific distribution. Osteoarthritis is in a sense a type of degenerative arthritis. So it follows the patterns of wear and tear, that is the parts of the musculoskeletal system that have the maximum weight bearing or are commonly or frequently overused. These are the ones that get affected. So because of our opposable thumb, human beings, in the upper limb, the carpometacarpal joint, that is the first CMC joint, that would be this joint, and the DIP joints are affected, and in the lower limbs it is the hip and the knee joint. Now the ankle joint actually bears the maximum weight, but the ankle joint has a very thick cartilage which is very resistant to wear and tear. So osteoarthritis with the ankle joint is extremely uncommon and does not really indicate that the underlying cause is osteoarthritis. Now on the other hand, if the pattern of distribution of the joints is not that, that is, for example, there is ankle arthritis, then you must consider other possible causes of chronic non-inflammatory arthritis, and that is C for Charcot's arthritis, H for hemochromatosis, O for osteonecrosis. Now hemochromatosis, importantly, can also cause CPPD like arthritis. So it can produce pseudogout. So it could present as an acute arthritis. Similarly, actually in hemochromatosis, the classic arthritis is very similar to what you find in RA, and even in distribution, and it is very similar to that found in RA. But the more common presentation is this kind of an arthropathy. Now once you think there are features of inflammation, that is, you're thinking of a chronic plus inflammatory arthritis, we go in and check the number of joints and the symmetry of involvement. Okay, so the number of joints, if it is the cutoff given in Harrison is actually 3. Okay, 1 to 3 joints and more than 3 joints. There's a slight nuance there, so we'll get to that in a while. Now, if there are less than or equal to, that is 1 to 3 joints are affected, and or there is asymmetry in involvement, that is, if you draw a line from the center of the body, the joint distribution of joint involvement is not symmetric on either side, then we consider these possibilities. One is we consider chronic infections. Now, chronic infections, that would obviously be in India tuberculosis, and also less commonly but equally reasonable to consider in certain circumstances, fungal infections like histoplasmosis. Now, or it could be the your spondyloarthritis spectrum. So that would be your psoriatic arthritis and your peripheral arthritis as part of reactive arthritis, or even enteropathic arthritis, although enteropathic arthritis often is there is type 1 and type 2. So we'll get to that. We'll discuss that we'll discuss that under inflammatory arthritis, enteropathic arthritis. Now, oligoarticular JIA in the specific situation, as in if the arthritis started when the patient was younger than 16 years of age. Now, on the other hand, see what all we've covered. So this is a multifocal pain. It is likely articular. It is chronic, that is, it has lasted for more than 6 weeks, and there are more than 3 joints affected in a symmetric more than equal to 3 or rather more than 3 joints affected in a symmetric manner. Then we start thinking, okay, this is some systemic disorder that is affecting the joints. Now, this number of 3, this is a little arbitrary actually, and this doesn't exactly equal the term oligoarticular or polyarticular. So see, formally the terms oligoarticular and polyarticular are used in the ILAR classifications for juvenile inflammatory arthritis. Okay, so there the cutoff is actually 4, that is less than or equal to 4, and more than 4, that is more than or equal to 5. So oligo is less than or equal to 4 and poly is more than or equal to 5. However, here we have not actually considered that. Okay, so what I like to do clinically is, when you actually have 4 joints involved, at that point I consider both possibilities, both these conditions and the conditions that I'm going to discuss subsequently, and then I fine tune the diagnosis based on the other clinical presentation and other clinical features that the patient has. Okay, so going to the multifocal chronic, that is more than 6 weeks, symmetric arthritis involving now more than 3 joints, that is at least 4 joints. Now, in that situation, just prior to that, if you can recall, based on our first discussion in the series, why would this be important? Why would these disorders be more likely if there are only 3 joints affected, or there is asymmetry? Okay, so that is because that indicates that this is the underlying pathogenesis. Now, what is this? Basically, what is happening is that there is excessive innate immune activation, okay, and the feedback inhibition of the innate immune system by your Th17 to Th1 polarization is possibly not happening properly. So that could be the result of 2 types of separate immunological phenomena. One is there is a decreased threshold for innate immune activation, resulting in excess innate immune activation, and this the prototype of this being Behçet's disease. And the second disease that comes under this list is relapsing polychondritis, and I touched on this there as well. So the arthritis in these 2 disorders can be recalled using this mnemonic, that is NAME. That is, it is non-erosive, asymmetric, mixed, as in large plus small joint, and it is episodic. Okay, so as you can see in our diagnostic framework, it would end up landing up in that category, in this category. Okay. Similarly, this would also be the case in those parts of the musculoskeletal system that are exposed to the maximum wear and tear. But unlike what we saw with osteoarthritis, this would be chronic inflammatory arthritis. Okay. So that would be failure of Th17 to Th1 polarization, corresponding to what we discussed previously as a negative interferon signature, and that is obviously your spondyloarthritis spectrum of disorders. That is psoriatic arthritis, particularly the oligoarticular variants, the enteropathic arthritis, and reactive arthritis. So there is a block here. Because of that block, there is increased Th17 polarization, and that increased Th17 polarization increases the innate immune signaling more. So as we discussed in the previous discussion, this is your skeleton. This is the vector of gravity acting on the skeleton, and because there is an excessive sensitivity of the joints to innate immune active or to damp PAMP exposure, there is involvement of some joints, especially the weight bearing joints, and obviously it is asymmetric because nobody distributes their weight exactly equally between the right and the left, and when pain starts on one side, the patient tends to put weight on the other side. So there is prominent lower limb involvement, prominent asymmetry, and obviously because the joints affected are large joints, it is the number of joints affected is lesser than what that would be the case with other arthritis. So there is asymmetric large joint predominant, lower limb predominant arthritis with axial involvement. Okay, so there is axial involvement. Okay, now this is the spectrum of immunological disorders that we had derived previously. So this spectrum included increased innate immune activation, either due to primary defect in the innate immune system resulting in a lower threshold for activation, or a failure of Th17 to Th1 polarization, which resulted in a Th17 mediated secondary activation of the innate immune system, or it could be due to increased adaptive immune activation due to a targeted response against a specific antigen. So the prototype of this type of disorder being rheumatoid arthritis, which could again be seronegative or seropositive, and maybe even psoriatic arthritis, the polyarticular variant. Okay. Then the last group of disorders that we saw were the disorders in which there was increased innate immune activation, primarily due to adaptive immune activation augmenting the innate immune activation. So these were the classical alpha interferonopathies like SLE, systemic sclerosis, dermatomyositis, Sjogren's syndrome, and there you were developing a anti-nucleic acid binding protein antibody, which was resulting in the accumulation of those nucleic acid within endosomes in plasmacytoid dendritic cells or other cells. That was secondarily resulting in concentration of these nucleic acid binding proteins within those endosomes, and as the endosome became acidified, the nucleic acid dissociating from these nucleic acid binding proteins and then going and binding their respective TLRs, TLR 3, 7 and 9, resulting in more interferon production, okay, which resulted in more anti-nucleic acid antibody production. So in a way, the adaptive immune system became started activating the innate immune system rather than inhibiting it. Okay. So, and we had also discussed how in case of systemic sclerosis and ANCA vasculitis, there is a slight variation to this general thing. So we'll restrict our understanding to these disorders, that is axial spondyloarthritis, peripheral spondyloarthritis, that is reactive arthritis, enteropathic arthritis, and oligoarticular psoriatic arthritis, and like I just discussed, Behçet's and relapsing polychondritis. Dyslipidemia related arthritis and intermittent hydroarthrosis is a slightly advanced topic, and we'll get to it subsequently in our future discussions. Okay, now so, and we've discussed that ANCA vasculitis and systemic sclerosis arthritis is inherently different because of the vascular involvement in both disorders, and I've discussed this in some detail in part 1, and we'll get to it again later when we discuss the individual illness scripts of these disorders. Now what we need to do next is differentiate this large group of disorders from one another. Okay, and how do I do that? I use the same trick that I use for osteoarthritis. Okay, that is, I know that rheumatoid arthritis is far more common than the others. Okay, so the base rates of rheumatoid arthritis are much higher, and rheumatoid arthritis shows a very characteristic joint distribution, and we can leverage those 2 points in order to go forward and clarify our diagnosis. So now we have an arthritis that is chronic, that is, it has lasted more than 6 weeks. Okay, it is inflammatory, it has features of inflammation that we just discussed. It is symmetric, and there is involvement of at least 4 joints or more than equal to 4 joints. So in this context, the arthritis is likely to be due to a systemic autoimmune disorder. Now in that context, again, we ask ourselves, is the distribution of the joint involvement that typical for rheumatoid arthritis? Now what does typical for rheumatoid arthritis mean? It means there is involvement of the metacarpophalangeal joints and the proximal interphalangeal joints with sparing of the DIP joints. Now this does not mean that the DIP joints are not affected in RA, but they are affected in 10% of RA cases. Okay, so if they are spared, it strongly points towards RA, but if they are involved, it doesn't necessarily rule out RA. Okay, but again, if they are spared, we know that this is RA. Even if the serology is negative, this is RA. Okay, now if they are not in the typical distribution of RA, then it could still be RA, but it could also be SLE, systemic sclerosis, and polymyositis, or the other alpha enterpronopathies. Now, like I said, there is a bonus section on differentiating rheumatoid arthritis from polyarticular psoriatic arthritis. Now this is actually a very clinically difficult clinical question to answer. So what I do is I use a 3-step process. In the first step, I look for these 5 findings that are typical for psoriatic arthritis. Okay, one is obviously if the patient has psoriasis. Now again, none of these points in itself indicates that the patient has psoriatic arthritis and not RA, but you have to consider the entire quantum of evidence for and against. The second thing is if the patient has HIV. So obviously HIV increases the risk of psoriasis and psoriatic arthritis. E stands for enthesitis. Again, enthesitis is likely present in almost all cases of psoriatic arthritis. Okay, and this is actually very easily missed on the physical exam, and this is something that you must pay attention to while differentiating this kind of chronic, symmetric, polyarticular, or more than equal to 4 joint inflammatory arthritis. Then nail changes. Nail changes usually develop only in psoriatic arthritis, and they are not so in RA cases. And finally, there is dactylitis. Around 1/3 of patients with psoriatic arthritis also have dactylitis. So again, E and D, that is end, is usually the end of the discussion. Okay, so if you have all 3, that is, you have enthesitis, you have nail changes, and you have dactylitis, then you are dealing with psoriatic arthritis, even if the serology is positive for rheumatoid arthritis. Now, if none of these things is there, then what we do is, we send a serology. Then you again re-examine the patient for any evidence of enthesitis, nail changes, or dactylitis, and then using these 2 entities, I like to make a 2x2 table. On one side I have the serology, which may be positive, which may be negative, and the other side I have end, that is enthesitis, nail changes, and dactylitis, which may again be present or they may be absent. So based on this, we can have very confusing situation in which both are positive. In that case, it is most likely psoriatic arthritis, because like I said, these are highly suggestive of psoriatic arthritis vis-a-vis rheumatoid arthritis. Now, if serology is negative and these are positive, again, there is no doubt it's psoriatic arthritis. On the other hand, if serology is positive and none of these are present, okay, then it is rheumatoid arthritis. And importantly, it is the titer that matters. Now, if though the serology is negative and you don't have any of the 3 ends, that is, you don't have enthesitis, nail changes, or dactylitis, it could still be psoriatic arthritis or rheumatoid arthritis. Now, here the serology is most important. Serology is important because psoriatic arthritis can have RF positivity and anti-CCP positivity, but the titer is always low. So it is never or almost never more than 3, okay, times the upper normal limit. So if it is more than 3 times upper normal limit, that holds a lot of weightage for RA. And if there is enthesitis, nail changes, or dactylitis, that holds a lot of weightage for psoriatic arthritis. If neither is present, then you are left here, in between. And in that situation, I use the 3rd step. So Now, importantly, the Casper criteria that is used to classify patients as having psoriatic arthritis uses RF negativity as gives it a weightage, and that RF negativity is specific for one specifically should not doesn't implies that you should not use one methodology. That is, you should not have measured the RF by latex agglutination. This is an important caveat to that classification criteria. Okay, now finally, if all else fails, what I do is I use the following 6 entities: A, B, C, D, E, F. A for acroosteolysis. Okay, that is loss of the distal phalanx, the tip of the distal phalanx. This would obviously be a radiological finding. B stands for back pain, and because it's psoriatic arthritis, actually more specifically neck pain. C stands for Koebner's phenomenon. Now, here I mean deep Koebner's phenomenon. That is, just like you get Koebner's phenomenon in the skin, there is trauma to the skin, there the patient starts developing a psoriasis lesion. Similarly, when there is trauma to a joint, the joints can get inflamed in patients with psoriatic arthritis. So this is what we call a deep Koebner's phenomenon. K for C is how I used it here. Okay. D stands for distribution. Now, distribution is what? Distribution is, two distributions are actually quite specific for psoriatic arthritis. One is the ray distribution. So ray distribution refers to the involvement of the MCP, PIP and DIP of the same finger. So it's like a ray is coming out of your out of the finger. Okay, it's involved like a ray. On the other hand, you could have simultaneous involvement of all the MCPs. So this is one row. So this is called the row involvement, or simultaneous involvement of all the DIP, the proximal phalangeal joints. So that would be row involvement. Okay. So again, distribution, very characteristic distribution. Then we have E, which stands for erosions. Now this actually I am talking about a very specific finding. That is, you get such severe erosions in psoriatic arthritis that the digits can start to go into each other. Okay, so that is called telescoping, or in French it is called an opera glass digit. I don't want to butcher the pronunciation, but I think it's called doit en lonet. Okay, so that's what it is called. You should, again, because of the factual nature of the MCQ exams that we write, at times you need to be aware of these terms, but that basically means an opera glass. So like an opera glass, what you find is that this is the digit, this is the normal digit, this is your MCP joint, this is your proximal interphalangeal joint, and this is your DIP joint. What ends up happening is that the middle phalanx telescopes into the MCP joint like this. Okay, so this looks like an inverted opera glass. So this is your shortened telescoped digit. So this has gone inside. Okay, so that is quite specific for psoriatic arthritis. Okay, now the last thing that I use is F for fibrous ankylosis. Okay, and fibrous ankylosis, again, ankylosis is not common in rheumatoid arthritis. You get asymmetric joint erosion in rheumatoid arthritis with very characteristic deformities. Those characteristic deformities, again, if present, strongly point towards rheumatoid arthritis. Okay, so these are the 3 steps I use to differentiate between psoriatic arthritis and rheumatoid arthritis. I hope that is clear. Now, finally, we've come to understand the role of base rates. We've understood that trauma and degenerative arthritis are much more common than inflammatory arthritis, and we need to offset that, the odds that are in favor of non-inflammatory arthritis while we are considering our diagnosis of inflammatory arthritis. Second, we've developed a sequential generalizable framework. We've using the following formula, that is, first, is it multifocal or unifocal? Okay, if it is multifocal, is it a chronic process, or is it an articular process or an extra-articular process? If it's really an articular process, is it an acute process or a chronic process that is less than or more than 6 weeks? Then if it is a chronic process, then is it a non-inflammatory process, non-inflammatory with the definite quotes that I discussed, or an inflammatory process? If it is a multifocal, articular, chronic inflammatory process, then is it involving only 1 to 3 joints, or is there significant asymmetry, or is it symmetric? And finally, if it is symmetric, does it fit into the characteristic distribution of rheumatoid arthritis? That's how you come to a diagnosis of rheumatoid arthritis. And as you can see, you have to jump through a lot of hoops. Okay, and I hope it's clear why you need to do that also. Okay, then we've understood the term inflammatory, how the term inflammatory arthritis is actually, it indicates the pretest probability that there is ongoing inflammation in the joint, rather than actually meaning that there is active, I'm 100% sure there is inflammation in the joint. Just points that to the fact that there is likely to be inflammation in the joint. Okay, then we will try to, I extended this framework especially at the point of your multifocal articular chronic inflammatory polyarthritis to account for the oddities of the of how spondyloarthritis differs from the other two types of immune mediated disorders in terms of its distribution. Okay, then we understood how the high base rates of rheumatoid arthritis mean that if it looks like RA in terms of distribution, it is RA. Okay, as long as you reach that point of the diagnostic. Now, finally, we are going to use describe how synovial analysis is used. Now, again, synovial fluid analysis is not that useful in many cases, but it is sometimes very, very important. Okay, so we'll see what those cases are. So there are two very specific purposes for considering synovial fluid analysis. One is if there is acute monoarthritis, okay, in a patient who is a known case of chronic arthritis. So this patient has chronic arthritis and there is an acute on chronic arthritis. The second situation is obviously trauma, but I don't get much of that. Okay, and the third situation is when I personally clinically suspect your joint infection or crystal associated arthritis. So this would be the first step in a diagnostic framework. Okay, now if that is the case, then I aspirate the joint. Now if I aspirate the joint, what I could get is hemorrhagic fluid or I could get clear fluid. If it is hemorrhagic, it is either a traumatic joint. Obviously there will probably be a history. There's either a systemic coagulopathy or the patient has a neuropathic joint. Now you can have a very dark colored fluid coming out of some specific disorders like in achronosis, okay, and pigmented illonodular synovitis, but again those are very specific considerations, and I'll get to them at the end. So for general purposes, this is where we stop. Now if the fluid is clear, we look for what are the counts of the fluid. So if the counts are more than 2000, that 2000 is actually the normal cell count within the synovial fluid. This is because the synovial fluid acts as the synovial membrane, or the synovium doesn't really have a basement membrane. Okay, so things can keep coming in and out. So the number of cells that you normally get in the synovium is actually more than 2000. Okay. Pardon me, not more than 2000, more than 200. Okay, but see, more than 2000 is something that is significant. Okay, then or we look for a differential count that shows more than 75% neutrophils. So if that is the case, then that is an indication that is the low cutoff I use. See, please remember the normal synovial fluid count is 200. I said it wrongly earlier. Okay, so if it is more than 10 times that is more than 2000, then we consider the possibility of septic arthritis. If not, then we are considering the possibility of a non-inflammatory arthritis. So 2000 is a very important number of TLC, and for DLC 75% is a very important cutoff. Below this, the synovial fluid is non-inflammatory, term non-inflammatory, again with the same air quotes that I discussed for the clinical features of non-inflammatory. Okay, now if it is more than 2000 and DLC is more than 75%, then I call it inflammatory. Okay, and inflammatory, the first thing I look for is crystals. Okay, if there are crystals, it is crystal associated arthropathy, and depending on the specific crystal morphology, we'll diagnose that particular crystal associated arthropathy. If however there are no visible crystals, then we send for gram stain and culture. Okay, now importantly, if the TLC is not just higher than 2000 and DLC is not just higher than 75%, that is, it's actually more than 50,000, and or the DLC is more than 90% neutrophils, then we are strongly suspecting your septic arthritis. Okay, so the lower cutoff for calling something inflammatory is 2000. Okay, but above 50,000, we are now strongly suspecting septic arthritis. Even if we don't find anything on Darmstadt, we call it septic arthritis. Okay. Similarly, the low cutoff for calling something inflammatory is 75%, but above 90% is almost definitely septic arthritis. So that brings us to the end of the discussion. Now, as you can see clearly, the diagnostic framework for arthritis is a little bit more nuanced than other diagnostic frameworks that I've discussed as of now, because this is not based on one single biochemical or physiological principle. It takes into account the epidemiology, okay, and it takes into account the pathophysiology of the disorders that are involved. Okay. However, most complicated diagnostic frameworks are the same, and going forward, we will be coming to such diagnostic frameworks, in which situation I hope you can learn the basic principles that I've used in this particular situation and apply to those situations. We face such situations clinically very regularly. So thank you, and I'll see you in the next discussion.